So please, colleagues, we have to the seat, so we can begin the latest session of the day. I hope that after all day hard working, we are able to still concentrate to this very interesting session. It is my pleasure to introduce Dr. Warongpon Phuenpathon from Chulalongkorn Center of Excellence for Parkinson's disease and related disorder. Her topic today is how to examine patients with gait disorders. So please, Doctor.
Thank you for your great introduction. And before we start the session, Dr. Jirada would like to say something about the questionnaires.
Just a little bit, because of the lack of the resource and the challenge in the PD treatment in our region, as we mentioned, from the initiation of the Indo-China Movement Disorder Conference. So we try to collect the information from our region. So we would like to invite you to answer the evaluation of the awareness of the medical staff about the Parkinson's disease. So to improve the diagnosis, treatment, and also the patient care in our region. This is the two parts of the awareness of the treatment and also treatment available in your country. And the second part is the knowledge, PD knowledge questionnaire. And please, you can scan this QR code and then you please answer your question. Yes, don't worry, you can answer that you want anything. Yes. Okay. So maybe go to the next session. Thank you so much.
Oh, yeah.
So, greetings to all participants, and it's a very great opportunity for me to be here. I'm Warongpon Phuenpathon, faculty from Chulalongkorn University. And today, I'm sure that gait disorders are common problems that general practitioners and neurologists face every day. So let's find out how to examine patients with gait disorders together in my talk, how to examine patients with gait disorders. To declare my conflict of interest, I received a PhD grant from the Second Century Fund, Chulalongkorn University. And before I give a talk about gait disorder, you have to understand about human gait and balance first. Human gait is a complex, rhythmical, and cyclical movement. It is controlled by a chain of movement disorders, a chain of command from cortex, basal ganglia, brainstem, spinal cord, and then peripheral nervous system. And what about the balance? Balance is the ability to maintain stance without falling or excessive lurching, which depends on multiple factors, including the vision, proprioception, vestibular sensation, and good motor control. After we understand the definition, we'll have to understand the pathophysiology. This will enable us to correlate and understand more about the clinical manifestation. As I said, that gait is controlled by a chain of command from the central and peripheral nervous system. First, when we want to walk, we'll have to know where to go, and then we initiate the walk from the frontal cortex, which then sends the signal to the mesencephalic locomotor region in the midbrain, and then send the signals to the pons here, then goes to the spinal cord. After that, the signal, when the descend to peripheral nervous system and activate the gait or locomotion. This correlates with classification of gait abnormalities. Abnormalities of frontal area will contribute to highest level gait disorder, including the frontal gait disorder, the cautious gait, the psychotonic gait, and then the abnormalities of brainstem, including the midbrain and the pons, and also the spinal cord will contribute to the middle level gait disorders. And then the abnormalities of the peripheral nervous system will contribute to the lowest level gait disorders, including the Steppage Gate and the waddling gait. So we'll talk about these abnormalities later on. Next, let's move on how to examine the gait disorders. We've already understood how gait abnormalities occur, which will contribute to what we should notice in gait examination. So in this topic, we'll focus on 3 topics, including the basic knowledge of gait examination, the details we should focus on, and the differential diagnosis. For the basic knowledge of gait examination, you have to know that steps of examination begins with sitting, quiet standing, walking straight for about 3 meters to evaluate the standard time up and go test, then advise the patient to turn and then walk back to the chair. What is the time up and go test I mentioned? The time up and go test is as its name, the standard time which patient stands up and walk. So we measure this as an objective gait measurement. It's a representative for gait measurement. So you can also advise the patients to perform the spatial test if needed, including walking backward, doing tasking like counting the numbers while walking, or walking through the narrow passage. I'll have to emphasize that details of each step can be used to differentiate between disease and gait disorders. And now, what details should we focus on? We learned about the gait examination, the normal gait examination. Now, what details should we focus on? Well, we are going to the abnormalities of each step. First, we are going to these 2 steps. At the sitting position and quiet standing, we'll have to monitor for the posture, balance, and motor activity. What abnormalities would we detect in these first 2 steps? The abnormalities include postural abnormalities or the postural abnormalities of head and trunk, which can be best observed when patients sit or stand. Then let's see the differential diagnosis based on the abnormalities detected. You can tell the diagnosis of patient at first glance on the chair when they come into your examination room. The common postural abnormalities of head include backward dropping of head or retrocollis, and forward dropping of head, or we call it anticollis. The picture on the left here demonstrates the retrocollis. When we found retrocollis on examination, the common differential diagnosis should include the PSP, of course. However, there are other lists of differential diagnosis as in the blue box here, and we'll talk about this later on. So what about anticollis? What we would think of when the patients have anticollis? The common differential diagnosis should include the atypical Parkinsonism, especially the MSA, and also the other neuromuscular diseases like the ALS or the myasthenia gravis also have the probabilities to have anticollis also. But please note that patients should have lower motor neuron type weakness or other specific signs along with anticollis if you suspect ALS or myasthenia gravis. Another thing to be considered is to differentiate between anticolis and stool posture. Or if the stooping is severe, we call it the camptocomia. As you see in the two pictures on the right, anticolis is considered when abnormalities are observed above C7 level of the spine and stool posture are below. Why you have to differentiate this? Because the differential diagnosis and the treatment are different. Anticolis is mostly found in MSA or other neuromuscular disease, like in the middle picture, while stool posture is mostly found in PD. The postural abnormalities can be found at the trunk also. If patients lean sideways in abnormal degree, we call this the pizza syndrome. This can be found in advanced PD and atypical Parkinsonism. Some patients with musculoskeletal problem can present with the pizza syndrome also, like patients with scoliosis or other vertebral abnormalities. So it has been listed here about the other differential diagnosis of the pizza syndrome. But the typical diagnosis you should mention is the Parkinson's disease. And what about the drifting backwards? Of course, we'll have to suspect for opisthotonnus, which may be caused from what we know, tetanus, or some types of poisoning. This can be found in atypical Parkinsonism like PSP and PD also. Another thing to be noted is that you see that drugs can cause all the postural abnormalities, especially the drugs in the type of the dopamine blocker or neuroleptic drugs. You see that it will be listed in all the postural abnormalities. Definitely, the frequently asked questions include how we should differentiate pathological postural abnormalities with normal variants in elderly. Recently, there is a consensus on Standard Movement Disorder Society Task Force. This demonstrates degree of normal variance and the pathological abnormalities. If the degree of abnormalities are low, elderly patients tend to have normal variance. All of you can follow the reference for the exact degree and further details. So if the abnormalities are severe, we'll consider they are having real postural instability, postural abnormalities, sorry. So what about the other abnormalities that can be detected in these first two steps? The other abnormalities include the abnormalities of balance and motor activity. When the patient rises from the chair, the abnormalities can be divided into reckless rising or slow rising. Reckless rising can be found in PSP, as known as the rocket sign in the left video. You see that this patient, when he tries to lift up from the chair, rise up from the chair, he fell back into a chair when attempted without attributed caution. However, in the right video, you see that this patient has slow rising caused by his proximal muscle weakness, or if extreme, it can also be found as gout sign in muscular dystrophy, like in the right video. Other factors can also confound the rise of patients, such as musculoskeletal problems or pain. Now we are moving to the abnormalities in the 4 steps here. Before we go to the abnormalities in that 4 steps, you have to know about the gait cycle. You can compare the demo picture at the first row with the real video at the second row. The gait cycle starts with stance phase and ends with swing phase. Stance phase is when any feet contact with the floor, and the swing phase is when any feet is in the air. In the stance phase, the first step is the heel strike and the beginning of the gait initiation. Then the foot is fully contact to the floor and ends with toe off. So what we would monitor in the stance phase, we can evaluate the stance width, which is divided into narrow-based and wide-based gait. Other things we can evaluate is the step length and the stride length. The step length is the distance between right and left feet here, and the stride length is the distance between the same step, like in this figure. In the swing phase, the abnormalities can be detected in the arm swing. So next, what details should we focus on? These 4 steps here. When patient walks straight, turns and walks straight back to the chair, we'll have to monitor details as listed, which are correlated with the gait cycle I have previously mentioned. The special test can be performed if you don't see the abnormalities in the basic examination. So what abnormalities can be detected? They're listed as following. So let's see the details of abnormalities for the differential diagnosis. And the first one is the freezing of gait. Abnormalities of gait initiation, maintenance, and termination can be observed as freezing of gait. So freezing of gait is defined as a brief episodic inability to generate effective steps despite the intention to walk. It doesn't occur all the time and has various clinical manifestations, depends on the provoked situation, like when patients are at the start, turning, approaching the target, or if severe patients can have freezing when they walk in an open space. This spectrum of presentations can be found in PD or frontal gait disorders. So now we are moving to the second abnormalities, the abnormal stance width. Abnormalities of stance width can be divided into wide-based and narrow-based gait, like I've mentioned in the previous slide. Wide-based gait can be found in cerebellar ataxia. You will also notice that there are dysmetria of each step, but it is consistent in all of his steps. Patients with NPH in the second video also has wide-based gait, but you'll notice that the step is a little bit short and she hardly lifts her feet from the floor. The most important thing in the second video is the arm swing is normal. You see that her arm swing is normal. So we call this the lower half Parkinsonism. The next video is the patient with MSA or a typical Parkinsonism. He has wide-based gait, but the difference is that you see that this patient had postural instability in the medial-lateral plane, like some speakers mentioned in the previous session. Patients with PD have narrow-based gait to compensate their postural instability in anterior-posterior plane. And the last video is the patients with spastic gait. You see that they have narrow-based gait due to their muscle spasms. Now let's move to the third abnormalities, the abnormal steps. They can be divided into reduced step height, increased step height, and irregular or asymmetrical cadence. Reduced step height can be found in Parkinsonian or frontal gait like this, because patients have brady or sometimes hypokinesia. It can also be found in neuropathic gait like this video, in which patients have weakness, so they cannot lift their feet from the floor, and the step height is reduced. However, the increased step height can also be found in choreic gait here. An example is a levodopa-induced dyskinesia, as known as the silly walk. You'll see that this patient has stamping with high step height. And also that his arm swing is also increased. For the last video is the patient with the cerebellar ataxia. You will note that this patient has irregular or asymmetrical cadence, or you see that the steps of the patients is very irregular, which can be found in cerebellar ataxia. Sometimes this type of abnormalities is also found in patients with psychogenic gait. Now we're in the fourth abnormality, the abnormal arm swing. The abnormalities of arm swing can be divided into decreased and increased arm swing. Decreased arm swing can be found in Parkinsonian or Dystonic gait. You see here in this video. The first video on the left is the patients with Parkinsonian gait. And you see that there is a symmetrical arm swing. This is a patient with Dystonic gait. You see that her foot had abnormal posturing and her elbow is hardly flexed with a type of Dystonic gait. So you'll see that this patient will have decreased arm swing. So for the increased arm swing, it can be found in levodopa-induced dyskinesia here, or even in psychogenic gait. Okay. And the last abnormalities in movement fluidity. Movement fluidity can be divided into decreased and increased fluidity. Decreased fluidity can be found in stiff gait, as in stiff person syndrome. You see that this patient is walking with rigidity. It can also be found in Parkinsonian gait, as PD patients also have rigidity. What about increased fluidity? The increased fluidity can be found in psychogenic gait, as known as the type of knee bucklings. This is a sign which is very specific to psychogenic gait. And increased fluidity can also be found in other types of gait, like the Trendelenburg gait. The patients have fluidity of pelvis when they walk because they have proximal muscle weakness. Before the end of the examination, physicians can perform additional tests as shown. It supports the disease you suspect. The rumble test is performed by patients moving the feet side to side, folding the arms to the chest, eyes closed. This test will elicit sensory ataxia. The next test is the Tandem Gate, which is performed as shown on second video from the left. The test can be impaired in patients with medial lateral instability, such as atypical Parkinsonism and ataxia. Walking backward can be used in Dystonic gait to elicit task-specific dystonia and functional gait to demonstrate inconsistency. Also, walking rapidly can also be used in patients to provoke freezing. So how do we apply the gait examination into the detection of gait abnormalities, as I previously mentioned? This consists of the highest, the middle level, and the lowest gait disorders. Some are previously discussed, but I'll mention the common gait disorders and what we should observe to recognize each type of gait disorders. This is an example of how to put each fragment of observation into the whole picture. The first example is the frontal gait disorder. Patient will have wide base gait, decreased step length, and they hardly lift the feet from the floor. Or we call this the magnetic gait. The most important thing is the arm swing is normal. All of these are features of frontal gait disorder, which we'll go through this topic in the next section. Another example is the middle level gait disorder. The Parkinsonian gait, the common middle level gait disorder. In the sitting and standing position, patient may have stool posture here. When they walk, they may have freezing. When they start, the gait is slow. And also the gait has narrow base and reduced in step height. There is also a decreased or asymmetrical arm swing, which can be observed like in the last video here. You can see that every features I've previously mentioned is looking into the whole picture as in this slide. After observation of every features, then you can decide that this patient has Parkinsonian gait. Another example is the Ataxic Gate. As you see in the videos, patients will have wide base gait, irregular cadence, and also impaired tandem gait. Ataxia can be divided into cerebellar and sensory ataxia. And we can exclude these two disorders using the Romberg test. If the Romberg test is positive, which means that patient tends to fall after they close their eyes, you should suspect sensory ataxia. The next one is the Steppage Gate. You see that this patient has reduced step height and her hip and knee is excessively flexed because she hardly lifts her feet from the floor, from the weakness. So this is the character of the Steppage Gate. And this is the lowest level of the gait disorders. So for my conclusion, gait examination should always be performed in patients with neurological disorders. It can tell us many diseases. And you see that there are steps of examination, including from sitting, standing, walking, and turn. Careful observation is a key to differentiate disease with gait examination. So when you examine patients with gait disorders, I suggest that you should carefully observe details of each phase and put them together into the whole picture. This will lead you to the differential diagnosis and prompt management of the patients. In the next section, we'll have discussion on various cases of gait disorders so that you can understand more about each type of the gait disorders based on the cases. Thank you for your attention.
Thank you, Dr. Warren Pon, Phu and Patton, for a very interesting presentation with many videos. In this presentation, Dr. Warren Pon give us two levels of gait disorder, highest, middle, and lowest. And we have two topics to examine. So please, dear colleagues, we have a few minutes to give her a quick question or comments. Please. Yes, please propose.
Very nice session. And I think that you put a lot of good videos and examples. So it's clearly seen. It's not really the question, but I just want to point out that what we see when patients walk to us is not just only the abnormalities of the underlying disorder, but it's actually the compensatory mechanism that their patients actually try to compensate with it. I think one of the good examples is the wide-base gait that you see that is actually patient trying to compensate it. So my question, not really the question, so maybe you could comment that when approaching patient with gait disorder in which we could have cases to discuss, to tease out what is actually the abnormalities, what is actually the compensatory mechanism, or even the aspect of fear of falling that the patient manifests when they, manifest themselves. I think it's quite important when planning for the treatment. You want to mention about that a bit?
Yes, thank you, Professor, for a very good question. Some like Professor has said that some patients may have compensation, which means that it's not the real abnormalities. is the compensation of the patients. How to differentiate this? There are many methods to differentiate the compensation from the abnormalities, including also the spatial taste is the one that we can use to differentiate between the compensation and the real pathology. Like in patients, for examples, like in patients with dystonia, when the patient walk forward, we will notice their abnormalities are very much more than when they walk backward, which leads us to the diagnosis of task-specific dystonia. This is some of the examples, but there are many examples more than that. The key is to observe patients in many situations, and also if you are not sure whether what types or whether it's the real abnormalities or not, you have to perform the spatial test.
Please. Any else? No question. Yes, Dr. C.
Thanks for your interesting presentation. Because everybody have their own gait, right? So what is the criteria for wide or narrow pace, or long or short step, small step? Because sometimes we have argument. Some doctors say it's a small step, but other doctors say it's not, it's normal. So what is criteria for small or abnormal small step?
Oh, thank you for your very good question. So I'll divide the answers into two parts. The first part is there any numbers for you to tell whether it's the short or the long? There's still no consensus of the exact number to tell, but we have many literatures reviewing in the objective measurement of each type of gait abnormalities. Like if the patients with Parkinsonian gait, there are some reviews that tells that patients have the step length of about 30 to about 50 centimeters. So if you want to differentiate between the short or the long or the reduced step height, I recommend that you should compare with the normal healthy people with the same age, because if the age changes, the patients are older, the step length and the step height is revealed to be shorter. So when you compare, you want to tell whether the patients have the abnormalities of gait or not, you have to compare with the healthy people in the same age. But for the exact number, you can review the literature based on the abnormalities or the disorders.
So thank you for the question and this discussion. And now it is time we move to the second phase of our session today. Again, Dr. Warongporn Phuenphathorn give us a video-based case discussion on gait disorders. Please, Doctor.
Thank you for your great introduction again and seeing you again in this section. So we are moving to the video-based case discussion on gait disorder. So my first case is a 70-year-old male with gait difficulties for 4 years. So please see his examination at the left compared to the right. Any volunteers want to describe some of the gait.
Just the description would be good, I think.
Thank you.
Okay.
On the left video, I see the patient with difficulty in initiating the gait. And when we compare the right step and the left step, the left step is longer than the right step on the left video. But in the right video, we can see the longer of step is longer, better with the mark, laser mark on the floor. Right.
Okay, so you are telling that this patient having short step length and reduced step height, something like that?
Sorry. Can you
okay, okay, thank you very much. So thank you. In the video on the left, you see that his trunk leans to the right a little bit. This is a kind of Prisa syndrome, and the base of the gait is narrow. The step length is short, and there is also the reduction of the step height. You see that some of the steps occasionally freeze, and there is also a decrease in the arm swing. I would like to add further examination of this patient. We found that he has asymmetrical Parkinsonism more on the right, and no weakness is observed. So would you like to tell me what gait abnormalities does he have? Which types of gait abnormalities do you think this patient have? Oh, I'd like to add the E, sorry. Parkinsonian gait. I'm really sorry. You can add that for me.
I think it's the steep gate.
Okay, the kind of steep gate. Okay.
Or freezing gate.
Okay, freezing of gate. Thank you very much. So I left the E for all the participants to add that for me. Thank you very much. Thank you. Please sit down. Thank you. So this is what we call the freezing of gait, a type of gait which is found along with the Parkinsonian gait in the middle level gait disorders. So there is a clinical spectrum of Parkinsonian gait disorder, depends on the stage and the duration of the disease. In the early stage, as in the first patient, she seems to walk normally by observation. You see that? If we don't tell that this patient have abnormalities, somebody cannot notice that she really has abnormality. But when we provoke the abnormalities by advise her to perform the spatial tests like dual tasking or sometimes counting the numbers while walking, then we see the abnormalities. And for the second video, you see that there is a symmetrical arm swing. This is the progression of the gait disorder. The first two videos is the patients with the early Parkinsonian disorder. And the last video is the patients with the late stage. You see that the base of the gait is narrow, the step is short with the low numbers of heel strike. And also there is fascination. What is the fascination? It's a tendency to move forward with increasingly rapidly. And the steps become smaller and smaller associated with the center of gravity because the patient tends to fall. So they have to move their feet very quickly, very rapidly, and sometimes smaller. In the late stage of PD, some patients may also have freezing. As I said in the previous section, that freezing doesn't occur all the time. So it has various clinical manifestations, depends on the provoked situations, like when patients are at the start, turning, approaching the target, or if severe, patients can have freezing when they walk in an open space. And freezing can occur in different situations in relation to dopaminergic medication. This demonstrates that FOG or freezing is partially involved the dopaminergic system. Of freezing is found in majority. You can see in the left video that freezing improves after we increase the dopaminergic medication. And for the right video is the patient with the on FOG, which means that freezing can be found in both off and on stage. Why we can tell that these patients have on freezing? You see that her upper limb is very fluidity, moves quickly, and sometimes some patients have dyskinesia in their upper limb. So you can tell that this patient has on FOG. And for the right video, you see the left video, this patient has freezing of gait. But you see that after using some devices, the patient has improvement of his gait, right? What is this device? It's a kind of external cues. Cues are non-pharmacological methods to improve patients with freezing of gait. And there are many types of cues, including visual, auditory, or sensory. Each patient responds to each cue differently because the mechanism of action is different. However, there are common mechanisms. Cues improve the attention of patients. The patients pay attention very much to the light of the device. And also the compensation enhance, which preserve the spatial temporal control of the gait. And now, so let's go to the next case. This one, I think the video is not that difficult. So any volunteers for me to describe the videos? And then you can decide what abnormalities do they have.
Do you have the answer?
We can see here the left leg of the patient is stiff. The foot cannot. There is a stop between the foot and the floor. I think generally we can use the name is the Steppage Gate. Steppage.
Okay. Gate. So you think that this patient has Steppage Gate? Is there any abnormal posture of the foot?
You can see is the.
And what about the movement of his hip?
I can use the word is the internal rotation and inversion of the foot. Inversion of the foot.
Great, great. Thank you very much. So you'll notice that there is abnormal posturing of left foot and the inversion of the left foot when he walks. You notice that. And I kept the further examination to myself. So I would like to add some of that. Further examination found also the asymmetrical Parkinsonism with levodopa response, and no weakness is observed. And you notice that the hip of this patient, it is not in the circumduction movement. If we suspect for the spastic gait, you have to differentiate between these two with the hip. If the patients have muscle spasm, then he hardly lifts the feet and also the hip, and then there will be circumduction abnormalities of the hip. There will be things to differentiate between these two. So I'll go to which types of gait abnormalities do you think this patient have? I think, and I heard some whispering. Dystonic Gait, okay. Thank you very much. So this is what we call the Dystonic Gait in the middle level gait disorders also. So you see that an early manifestation is the inversion of the foot when the patient walks, and the great toe can be flexed or sometimes can be extended. When it worsens, there can be more abnormal posturing at the legs, at the trunk, and the arms. And patients may improve when they walk backward, like Professor Pichirasiri has asked me about the kind of compensation. So when the patients walk backward, some patients with mildly dystonia improves. And sometimes running can also be spared. So you see that the abnormalities occur only in the forward position. But if the abnormalities is very severe, the dystonia is fixed, and you see as kind of abnormal posturing at his foot. So this patient has dystonic gait, and we approach the etiology of dystonic gait in the same way as dystonia. It can be classified based on age of onset, body distribution, and also the etiology. So you see here that I compare the old classification and new in this table, and the old one is easier to remember and approach. The etiology can be divided into isolated and combined dystonia in new classification, as you see in the red box. And the etiology of isolated and combined dystonia are subdivided as shown. In this patient, he has dystonia and Parkinsonism, so he would have what we call the combined dystonia, right? And the cause of the patients with dystonia and Parkinsonism will be listed as shown. The dopa responsive dystonia, the rapid onset dystonia, and the young onset PD. In DRD, the patient will have onset of disease around 20-year-old. And for rapid onset dystonia, the progression will be very quick at very young age. And if the patient has YOPD, like in this patient may have foot dystonia and early motor complication, and this compatible with our case. So the cause of dystonia can be also simply classified into primary and secondary dystonia. And because this patient has clinical of Parkinsonism with dystonia compatible with young onset Parkinsonism, his etiology is in the type of secondary dystonia as shown in the red box. And before the end of this case, I'd like to emphasize the red flags of secondary dystonia. In this patient, she has the presence of other neurological or systemic signs, which indicates combined dystonia and leads us to the diagnosis of the idiopathic Parkinson's disease. And also combined with the neurological signs of asymmetrical Parkinsonism. The next and the last case, here is a 50-year-old male with gait difficulties for 5 years. As I've previously mentioned that sometimes you can tell what disease this patient have since they come into your room. So any volunteers for this video? Thank you very much.
I see this is the patient with the wide-based gait and small step, and it's so hard. He moved very slowly with the magnetic gate. I think so. I think this he has the magnetic
gate.
Yeah.
Do you notice the postural instability? You think it's the kind of wide-based gait, right?
Yeah.
But the postural instability is very distinct. You see that there are two people hanging around the patient. Is there any type of wide-based gait with marked postural instability?
I think that is Ataxic Gate. Another word. Yeah.
Thank you very much. So you notice that this patient has poor balance, and what you notice is that he has wide-based gait. Also, the stepping, you see that the direction and the distance is very irregular compared to when normal people walk. It's very irregular and also somewhat dysmetria. And also you notice that there are purple bags, a purple bag here. It's a urine bag. So this patient has autonomic dysfunction, a sign of autonomic dysfunction. This is a kind of Ataxic Gate, which what is Ataxic Gate is a difficulty with motor control, which consists of a dysmetria, dyssynergia, variability of performance, and poor balance. And the characters, its distinct characters are irregularity of stepping, irregularity in direction, distance, and timing. And also you notice the wide-based gait. Now moving to the cause of cerebellar ataxia, just a short course. Cause of cerebellar ataxia is divided into the acquired and also the genetic cause. If the disease occurred in elderly like this patient, we suspect the acquired cause. In this patient, he has cerebellar ataxia, including with the autonomic symptoms and the progression of disease for about 5 years. Then it should be considered as the degenerative disease. The common degenerative cerebellar ataxia is the MSA. MSA is a type of atypical Parkinsonism, and patients may present with cerebellar ataxia or Parkinsonism with the red flags of autonomic dysfunction here. And other than cerebellar syndrome, like gait ataxia, limb ataxia, cerebellar dysarthria, or oculomotor features is one of the core clinical features in update criteria of MSA. And all of you can follow the update MVS criteria as following reference. So before the end of the case discussion, I'd like to emphasize that the middle level gait is very common in general practice. And the characters of each gait abnormalities should be carefully observed in examination, because you see that a little bit abnormalities that you notice can lead to the differential diagnosis and the disease of the patients. And early detection of each gait pattern leads to accurate diagnosis and prompt management of the patients. Okay, so next section, we'll have more cases from our colleagues from Laos. And so I would like to end my section today, and then let's follow the next section with our colleagues.
Thank you very much for your presentation. There are a question from the participant online for you.
I just want to point out that when we look at the patient gaits and we try to differentiate it, it's very common that we see the overlap feature. I think what you just discussed before, the potential of it being magnetic, like for example, because you observe some of the features that you think is overlapping. But at the end, we see the patient as a whole, and we try to decide what are the predominant features like in that, like in the case. Like in the last one, what you see, what is quite striking is the upper body sway that is supported by two people side by side. So probably that's implied that that is a mediolateral sway quite significantly in that patient, combined with the presence of the catheter, and that is what is thought to be the more ataxic nature per se, and the poor foot clearance that might be related to what how patient is trying to compensate it, because with the fear of falling and the instability of the trunk of the upper trunk, he would be fearful to lift his foot off the ground.
Yes, the question is, how could we differentiate between Steppage Gate and Paraparietic Gate?
For the characters of the stiff leg, you see that there, like Professor has said, that there are some types of gait that has overlapping features, like these two gait abnormalities from the questions, the Paraparietic gait and also the stiff gait. There are overlapping features like reduced step height. So sometimes some people can misunderstand the observation. But the things that will help would be the movement fluidity. But it's not 100%. So you need further neurological examination also. The movement fluidity in the patients with the stiff gait, will be decreased. But in the patients with the Paraparietic gait, the movement fluidity will be the same, or sometimes it's not markedly decreased. You can differentiate between these two with two things. So the movement fluidity, the first one, and the second one is further neurological examination. You see that the Paraparietic gait, the main abnormalities would be the weakness and also the hyperreflexia. If it's the upper motor neuron weakness.
Yes, thank you. And I also ask you a question. How do you differentiate between the cerebellar Ataxic Gate and frontal Ataxic Gate?
Frontal and cerebellar?
Yes.
Oh, yes. So the distinct feature, at first, we'll come into the pathophysiology between these two. The frontal gait disorder is caused by the abnormalities of the frontal gait, right? So the abnormalities between these two start from the first phase of gait, from the gait initiation at first. The frontal gait disorders will be slow. There will be slow gait initiation. And also the step of the patient will be reduced. There will be short step length. The patient hardly lifts the feet from the floor. And also the stance of the base is wide, but with the correlation of the abnormalities I have mentioned. So you notice that they are not the same. If the patients have cerebellar ataxia, the initiation will be good, not so bad, because there are no abnormalities at the frontal cortex. And then when you walk, there are dysmetria of the steps. It's the distinction from the pathophysiology if you don't want to remember the abnormalities of each one.
Yes, so the last case, do you think that case is the frontal Ataxic Gate? It's not Cerebellar Gate because the patient have the pace wide and slow step and slow movement, something like frontal Ataxic Gate.
Yes,
Than
yes.
Cerebellar Gate.
Thank you. I think that you mentioned a very good point because some have already mentioned that we have to differentiate between these two. There are also overlapping features. And also we can confirm whether this patient has each type of abnormalities with also the other neurological examination. Like if you want to confirm that this patient has cerebellar ataxia or not, you can perform the other neurological examination, right? I think it's a good point also. Thank you very much.
Thank you so much again. And we would like to invite Dr. Abason Paumin for your presentation case discussion. Dr. Abason Paumin is a neurologist from Setan Tiras Hospital, University of Health Science, Laos.
Thank you very much for your kind introduction. Xin chào. Hello, everyone. My name is Apason Pumin. I am a neurologist from Laos. Currently, I am a first-year movement disorder at Chulalongkorn Center of Excellence for Parkinson's disease and related disorder. This is going to be my first talk on international stage. So I would like to take this opportunity to express my appreciation to the organizing committee for having me here today. I am going to start my talk by showing you some video of the patients that you already may have seen. So this is like the postcard that you're going to have. These two patients came to clinic because of having a gait difficulty plus cognitive decline for more than a year. And these two patients have a specific gait pattern. It seems that they all have gait difficulties. In other words, gait disorder. So what is gait disorder and what pattern of gait do they have? Gait disorders are common disorders that usually found in all adults and increase by age. For the group of 60 to 69-year-olds, it can be seen about 10%. But at the age of 55 or more, it can be seen up to 82%. If you take a look at this flow chart, when patients have gait disorder that relate to age, falls always occur. When patients experience falls, it's always followed by either immobility, injury, or a fear of falling that cause them to end up with morbidity, quality of life decrease, and mortality. Gait disorders are very complex. This presentation will follow the classification of Nutt, Martin, and Thompson proposed in 1993, and it had been commonly used. There are three classifications of gait disorder, namely lowest level gait disorder, middle level gait disorder, and highest level gait disorder. The first two classifications have already been discussed by Dr. Valongporn, so I am going to talk only about highest level gait disorder. Highest level gait disorder is a malfunction of the cerebral hemisphere and include disorder arising from psychiatric origin. These disorders are not completely distinct from each other, so patients may have more than one characteristic and may progress from one to another. There are many subtypes such as cautious gait, frontal gait disorder, frontal disequilibrium, isolated gait initiation failure, subcortical disequilibrium, and psychogenic or functional gait. This is a figure showing a relationship of the three different subtypes arising from frontal lobe dysfunction. Frontal gait disorder, frontal disequilibrium, and isolated gait initiation failure are frequently difficult to separate from each other and might be considered various presentations of a frontal lobe dysfunction, as they can overlap by time. For example, patients can first present with gait aplasia, and later shuffling, freezing of gait, and poor balance can be seen. The common gait pattern in all adults are frontal gait disorder, cautious gait, and psychogenic gait. I'm going to discuss with this pattern in my presentation. I think all of you have already seen this video. Can anyone help me to talk about the phenomenology of these patients? This is like the post-test. This is a patient of 15 years old female who has cognitive decline for 1 year and have gait difficulty, as you can see on the video. Can anyone tell me her phenomenology and the sign that you see?
Yeah, this is a very good video that contrasting with what Barongpon shown in the last patient actually. Let's try again.
Thank you. I see that this patient have a Y-based gait, small step, and normal arm swing. And the history patient have a cognitive decline for 1 year. I think this patient have a magnetic gait and their NPH, maybe diagnosis for this patient.
Yes, thank you very much. That is the correct answer. Dr. Barongpon is very happy. This is the magnetic gait. And you can be seen in frontal gait disorder. Frontal gait disorder is most common pattern in highest level gait disorder. It looks like Parkinsonian gait as the patient present with short shuffling step, poor balance, initiation failure, hesitate on turn. This is called magnetic gait. But if you have a look at the other book, or maybe people other might discuss as the march apetipa or aplasia of gait. To differentiate with the Parkinson disease, this kind of pattern, patients do not have the abnormality on the upper limb. There is no tremor, and most importantly, there is no response to levodopa. This kind of pattern is called lower half Parkinsonism or lower body Parkinsonism. This is common differential diagnostic of frontal lobe dysfunction categorized by different etiologies such as vascular, pressure-related, neurodegenerative, autoimmune, and neoplasm. The most common and had been studied the most is normal pressure hydrocephalus and frontal temporal dementia. Normal pressure hydrocephalus is first described by Hakim and Adam in 1965 as a ventriculomegaly with normal CSF pressure. There are 3 important signs and symptoms: gait disturbance, progressive cognitive decline, and urinary incontinence. There is no diagnostic test for NPH, but there are some supportive tests. The recommended brain imaging is MRI with CSF flow study. If the MRI is not available, just like in my practice in my country, MRI is not available in every hospital, so CT scan is also helpful. Plus the event index to calculate the maximum width of frontal horn, then divide by the measure of the inner table at the same place, and it should be greater than 0.3. For easily understand, A divided B should be greater than 0.3. The best test that should be performed is TAP test. It helps in diagnostic the NPH. In addition, it is the best predictor of the response to the shunt surgery that is an effective treatment for NPH. TAP task is a lumbar puncture to remove 30 to 50 ml of CSF and observe the change in gait and cognition. If it is responsive, shunt surgery can be indicated. The surgery has a clinical response to 30 to 90%, and gait disturbance is a clinical symptom most likely to respond to this surgery. Now let's move to another video. Can anyone help me to describe the phenomenology of the patients and the sign that he has? This is a 70-year-old male present with cognitive decline and gait difficulty for a year. Can anyone? The post-test.
I think he presented very well.
Yeah, okay. In this video, we see a man with a narrow space, small tap, and when the patient walking the narrow space, the gait is we call it freezing up gait, and he must use some cues to help him to overcome that narrow space.
Do you see other side?
Other side.
When he tried to walk to the door, what happened?
Is the narrow space and small step when
Yes.
when he tried to overcome the narrow space.
Yes, that's correct. When he tried to pass the door,
Yeah.
he has some target hesitations that induce the freezing a little bit in freezing of gait. So these patients, when we do the brain imaging, he has the frontotemporal dementia. Frontotemporal dementia is first reported by Arnold Pick in 1892 as a clinical syndrome associated to frontotemporal lobe. FTD is the fourth common dementia behind Alzheimer's disease, vascular dementia, and dementia with Lewy body. It affects 1 to 16% of patients with dementia. Unlike Alzheimer's disease, FTD always occurs at middle-aged adults, as age at onset is between 45 to 64 years old, that is up to 60%. 10 to 15% appear to inherit in an autosomal dominant, and the three mutation genes are MAPT, GRN, and C9orf72. There are two subtypes. Viral variant is the most variant, nearly 60%, and the other one is primary progressive aphasia, that is about 40%. The PPA is divided into three subtypes: semantic variant, non-fluent agrammatic variant, and locopenic variant. When this is progressed, gait disturbance can be seen in every subtype. Now moving to another example of gait pattern. By watching this video, can some of you tell me what is this sign? You already seen this video before.
You have the privilege of picking the next one.
Are we picking the next one?
Yeah,
Yes.
you can pick the next one. You have the privilege.
Yes, I think this knee buckling.
That is correct.
Yes.
That is knee buckling. How about the second one? Oops. Can anyone help me?
I see the patient had wide space gait, and the arm swinging are normal, and he has maybe stoop posture, maybe I guess the diagnosis is Ataxic Gate.
That is very good answer. Actually, the first patients present with the knee giving away. This is the knee buckling. And the second patient present with broad-based step with decreased stride length and height. This term is called walking on ice. And these two patterns are seen in psychogenic or functional gait disorder. This is the 7 feature of psychogenic or functional gait disorder initially elaborated by Lampert. The most common feature is knee buckling, walking on ice, that is a mimic ice skating or as if on slippery ground. The other common sign was highlighted in the red color. I would like to end up my presentation by taking home message. It is very common in all adults to have gait disorder, and it is increased by age. It could be seen up to 82% at the age of 55 and more. Gait disorder induce falls. Patients end up having a lower quality of life, or in worst case, it increased mortality rate. There are many gait patterns in highest level gait disorder. Thus, there are clues to help in differentiate or diagnostic subtype. And this is very, very important to identify subtype and manage by its cause, because it could help in fall prevention. Last but not least, I please remind that the early detect gait disorders cause can help in fall prevention and promoting better quality of life for patients. So thank you very much for your kind attention. Cảm ơn.
Thank you, Dr. Abason Phaumin, for your presentation. Do you have any question and comment?
Just have a quick comment here. I don't know if the audience have the problem like when I used to be a junior doctor and a resident, that when I see all these videos, I was confused with all the terminology used in the literature. Because when you go back to the literature, many of them are quite old and many of them are descriptive. So you encounter the descriptions of various sources of the guide, and sometimes you get confused. Like, for example, you see frontal ataxia. What does it mean? Is it frontal or is it ataxic? Gait apraxia, frontal apraxia. How could the frontal lobe be apraxic? Something like that. Or subcortical disequilibrium gait of the elderly, sometimes Brun's ataxia and so on. And I think that I just want the audience to realize that these are from the old literature and they are descriptive. And with the advances in the investigation and technology, particularly with the neuroimaging, those has been classified. So, I mean, for me, I think it's easier to go by the classification. And once we go by the classification, we can match it with the description. And I think that you will understand more, like why that happened. Like when you realize that higher level gait disorder, like a frontal, they walk like that, what we discussed, you would not be confused that why they call it apraxia, which is not indeed not apraxic at all. It's a misnomer, but it has been used from old days. So it has so it continues to be used, to be described. Yeah, just a comment.
Thank you. Any comment and questions?
Okay, I have one question for Dr. Abason. Because you in your presentation you said that a knee buckling gait maybe in some functional gait disorder, but in some patient with negative malconus in pose of the legs, they may have the knee buckling gait. And therefore, is there any specific other signs for distinguish those in the functional gait or negative malconus in both of the patient's leg? Okay, thank you.
Thank you for the questions. Since I don't have much experience on the gait disorder, may I pass this question to our gait expert, Dr. Valongporn, to help me?
That is a very good question, though. Okay.
So yes, you mentioned a very good point that some patients like you mentioned in patients with myoclonus, right? Or okay, the negative myoclonus and the knee buckling. So the negative myoclonus will be characterized by is you have to do some postures, and then you see the lap. We call it the lapping of the movement. But in patients with knee buckling, is a very typical form of patients with psychotic disorders. But in patients with negative myoclonus, there are some types of gait too. If you differentiate between only the negative myoclonus and only the knee buckling, you have to see the lapping features of the myoclonus. That will help you to differentiate between these two. But in patients with negative myoclonus, they have some types of abnormalities that can be present into the what we call bouncing gait. Yes, if the patients have negative myoclonus, if the negative myoclonus occurs in the lower limb, not only the upper limb like we usually found that, the gait will be called the bouncing gait. Yes, the bouncing gait, not like this type. This is only when the patients, like we call it the buckling, only like suddenly fall, something like that. But the bouncing gait is like somewhat we call the dancing gait, like the patients bounce and sometimes dance, and we will have to differentiate that with the choreic gait also. but to say simply, you can simply differentiate that with the maneuvers like what I've told you, the lapping phenomenon, and also if you want to see the gait disorders of patients with myoclonus, you will have to notice the bouncing gait.
Maybe Veronpont, tomorrow you can put the video side by side actually between that knee blocking and the bouncing gait. I think that will quite show the contrast, because in that bouncing gait is a whole axial that is involved. And you can see that it goes together like that. And once the upper part is involved, usually patients have this type of instability and they require the carer to support them. And you can see that the knee buckling is very different. Sometimes it's quite almost like aesthesia evasi when you do like that, but it's not exactly the same. But you see that it's just the lower part is more involved. Why the upper body, when the patient is able to maintain without any foot correction. So the patient didn't do any foot correction.
There is a question for Professor Ron Roy from the participant online.
Yes.
Yes. What do you do for MSA with laryngeal stridor in real practice? Do you think about RTMS for MSA?
Or the treatment for the laryngeal stridor, you mean?
Yes.
Okay. This is very important question actually, because the stridor once occur is a poor prognostic risk factors in patients with MSA, and it has been demonstrated to shorten disease survival in those who have that stridor. However, the confirmation of the stridor in MSA patients, particularly in the early stage, could be quite difficult, because it's usually started in the nighttime, and the daytime the patients might look perfect. So the carer might say that, oh, he heard something, abnormal breathing sound at night, and during the day, the patient just fine. You refer the patient for the ENT examination, and they report it back normal. And I encounter this type of problem again and again. So in those who really suspected, we need to do the video stroboscopic study during the nighttime with the monitoring. And usually we documented those type of stridor. But it's quite difficult to do it in clinical practice, actually. So what I tend to do in practice is that if highly suspected, I usually, ask the family to do the camera at home. Is quite easy, actually. Nowadays, the device is quite cheap. And they do the, put on the home camera and do the monitoring for a few days, bring the video to us. If we highly suspected, we actually show it to the, to the ENT doctor. This is how the patient encountered during the nighttime. And I usually, brings the patient to do the monitoring at night in the hospital. If those is highly suspected. Now, if the patient who have the stridor during the daytime is not much of the problem because you can confirm it. Because sometimes, I heard the patients in the waiting room, they have this abnormal breathing sound, and we actually spotted it and then refer the patient for the proper treatment. So the treatment per se for those stridor, I think it is challenging because ideally the treatment of choice eventually for those patients is tracheostomy. But to do that, not many families really want to accept that. So sometimes you try to do whether, if that could be due to the dystonia, if it is dystonia, could that be, would botulinum toxin be helpful and so forth. But in that sense, in practical purposes, I find it's very difficult, to risk the patient to try with the toxin injection and so forth. So, I usually try to document it. And if the patient who have these severe symptoms have those stridor, they actually, the treatment of choice is actually a tracheostomy. And that has been shown to prolong survival, actually, in the patient with MSA. Dr. Srinkian, you have something to add? You're the nighttime doctor.
I totally agree with you. And
we can disagree.
Another one, another choice for the managed patient with stridor, sometimes might be we recommend the CPAP, the continuous pressure, to use during the nighttime. It might be a little bit help in the patient who don't want to perform the tracheostomy.
Yeah. Because, but I'm not quite sure if the CPAP has been shown to prolong survival in those.
No,
yeah.
I think no evidence for the prolonged survival.
And those with the stridor, since it is a life-threatening complication, sometimes want to do something more definite because I thought that it would be life-saving for the patient. Usually patients who have these type of problem, they are more advanced stage of the MSA, for example. And they already, some of them already aphonic, for example, they hardly able to talk, so maybe tracheostomy is a life-saving for them.
Maybe another study that said that if you cannot find the evidence of the stridor during awake, sometimes they scope under the anesthesia and make it more sensitive for detection of the stridor.
Yeah, that's right. But I like the home technology nowadays, with home devices and things, it's very easy to monitor patients at nighttime, and it's not that expensive. You ask, the son or daughter to set up the camera, and then you actually see it in a couple of weeks. They bring the camera to us, the clip to us, say, oh my God, this is quite striking.
Now, clinical practice, some case with mild and moderate severity, and I also use CPAP, and the patient will useful for the short time, 3 months or 6 months. Yes. Any questions? Yes, we had a long day for very interesting presentation, and I think it's very helpful for us to learn about. And I think it's time to stop today, and tomorrow we will meet together at 8:30, also in this room. Once again, thank you very much for the participant. Thank you.